Okay, this is the case scenario we shall go through with you all. And if you have any questions anytime, you can just ask. Okay, this is a patient with a history, a 52-year-old man presented with a 1-month history of pain over his left loin and blood-stained urine for 1 week. Okay, so this is the chief complaint. Pain over the loin, left loin for 1 month and blood in the urine for 1 week. And he's a 52-year-old man. The pain was a dull ache, not a real severe pain, dull ache in his left loin that worsened with time, and there was no radiation. The blood stain of the urine was throughout the urine stream, that's called total, throughout the stream. It was bright red in color, no history of trauma, and no history of passing stones. Also no history of fever or pain on micturition. But he noticed he lost some weight during this 1 month. He's a case of hypertension and diabetes for the past 5 years and is on treatment. Okay, now we come to analyze the symptom. I think it's quite straightforward. Okay, so you have got a 52-year-old man, 1 month history, blood stain, dull ache, worsen and all that. So what is one more history you have to get from this patient is whether he's a 52-year-old man, whether he has got some stenting of the heart done, heart problem, whether he's taking any anticoagulants or blood thinners or not. Very important, which is not mentioned. Hopefully, supposedly he doesn't have all that. Okay, so what are from the symptom analysis, these are the things. A loin pain with hematuria, dull ache is total hematuria and loss of weight. So it's a 52-year-old man. So these are the possible causes or diagnosis in this patient. Renal tumor can be benign or malignant. Renal stone, which is more common than tumor. And renal trauma, but in the history we are not told whether there is any trauma. Pyelonephritis, but this is unlikely because there is no pain on micturition and also there is no fever. Okay, and then medical conditions, acute glomerulonephritis, coagulopathy due to blood coagulants. So these are the possible causes from the symptoms. Okay, basing this in mind, we go to the examination. Okay, on examination, he looked well. That means he is not pale and he was not afebrile. BP 165/99 and pulse 82. The abdomen was soft and not distended. There was mild tenderness in the left flank. Okay, but the kidney punch or renal punch was negative. The liver and spleen were not enlarged, and the left kidney was vaguely ballotable and was slightly tender. A varicocele was also noted in the left scrotum. Okay, now again we come back to the analysis of the signs. Okay, he has got mild blood pressure, and you all know one of the causes of high blood pressure is from the kidneys. Alright, so whether is this relevant or significant, we are not sure. Mild tenderness in the left flank, okay, which is very significant, and a ballotable kidney. Okay, and he has also got varicocele on the left side. Again, left flank mass, and we know it is clinically, we think it is kidney. So it's an enlarged kidney mass on the left side with hematuria and varicocele. And varicocele is important because patients with tumor in the left kidney can cause compression of the testicular vein, and that causes varicocele on the left side. Then the possibilities now narrowed down after the signs. Left renal carcinoma, and the most common is renal cell carcinoma. can still be a stone, especially a large stone in the kidney with blockage leading to hydronephrosis. So the kidney becomes palpable or palatable. And in such cases, the kidney will also be slightly tender, which is so in this patient. Otherwise, it can be also associated with infection, okay, plus or minus. But this is very unlikely because there's no fever. Classically, a patient with renal infection, pyelonephritis, they will give high fever with chills and rigors. In this patient, it is featured, there's no fever at all. Okay. So basing on this, it is either a renal cell carcinoma or a stone in the kidney causing hydronephrosis and enlargement. Okay. So now I come to you. I open the thing to you all. Okay, what are the investigations you want to do? Anybody? Jyoti Mala? What investigations would you want to do for this patient? I put here as blood, urine and analysis. Okay, what are the blood tests you want to do? Jyoti, you are around?
Yes, okay.
What do you want to do for this patient? You got the history, give you the analysis of the symptoms and your provision clinical diagnosis. Now, what you want to confirm the diagnosis? What test you want to do?
Full blood count, WBC.
All right. Any full blood count?
Pardon, doctor?
Only full blood count. Anything else you do? Actually, there's nothing much in the blood test for this patient. It is basically a routine blood test. You want to do a renal profile. You want to do you want to do a liver function test. Okay. Then, if you think the patient is taking some anticoagulants or what, then you want to do a coagulation profile. So these are the few, and the platelet count. You want to look for the platelet count. So in our patient, okay, this patient has got a mass and hematuria. Okay, and hematuria, one of the common causes in our patients in our country is dengue. Dengue, normally they have low platelet count. So that's what you want to do in the thing. What about urine analysis? Shavina? Shavina, say something. Do you want to do anything in the urine to look for in this patient? Where you went?
Yes, doctor.
What do you think? Urine you want to do for this patient?
What is your question again, doctor?
Yeah. So in this patient, you want to do some blood test, you want to do some urine test. What urine test you want to do for this patient? Who you think has got renal cell carcinoma?
Not sure, doctor.
Not sure you want to do. You want to confirm got blood or not, isn't it? You say got blood. So how will you do confirm got blood or not?
Urine FEME.
Okay, urine FEME. So what do you look for?
Look for blood.
Yeah. What is you can't see blood like that. I see you have to look for what the evidence of blood there. Somebody say RBC cast. Yes, true. You want to look for RBC. Okay, whether the urine contains a lot of RBC or not. The way the patient is telling, he can see the blood in the urine now with his grossly with his naked eye. So that means there must be a lot of RBC. So when you look under the microscope, you will get packed with RBC. Okay, RBC packed. All right. Okay. One more thing you want to do in this patient in the blood in the urine. Jane Lim,
Yes, doctor.
what do you think?
Uh,
I will want to do look for RBC and also look for one more thing in this patient whom I think has got renal carcinoma.
doctor, is it protein in the urine?
Okay, protein in the urine. That okay. Anything else?
Uh,
Protein is very non-specific. Anything else which is more specific?
not so sure, doctor. Sorry, doctor.
Okay. If it's a tumor, what type of cell you will get in the urine? You do a urine cytology, you do a urine cytology, and this urine cytology will show malignant cells. You may be able to see abnormal cells, malignant cells in the urine. Okay, that's called urine cytology. Of course, protein can, CAS, protein, all these can be seen, but those are all routine tests. You don't really tell you whether your diagnosis is right or not. Okay, next one. Japsim, Japsim Ranjit, imaging, what do you want to do?
Ultrasound,
Okay,
see the kidney and the bladders.
okay, good. What do you call that in short form? K?
KUB.
Okay, good. Good. You want to do a ultrasound KUB. Okay, one of the diagnoses is stone. So would you want to do anything else before ultrasound?
We'll do a X-ray KUB also.
Okay, good. X-ray KUB and X-ray ultrasound. All right. I'll show you the pictures afterwards, and you can comment on it. Okay. Anything else? Any other imaging?
If it's a cancer, then do CT scan.
You don't know.
If you
How
don't
do
know,
you know?
yeah.
Now you are thinking it's cancer. Don't you say? So you must say, since our diagnosis is cancer, so we want to do a CT scan. Don't say if it is cancer.
Okay.
Because we are talking about this specific patient. So when you exam, when you present your case in the exam, the clinical case, you must present in relationship to your patient. Don't go and say, if this patient is cancer, I do this. If it's TB, I will do this. Now you have already made up your mind initially that this is cancer. So if we want to do or not, what do you want to do?
Contrast enhanced CT.
Okay, good. You want to do CT. Okay, I agree with you. Anybody else to disagree? Okay, this will be the initial investigation. Of course, you can do MRI, you can do IVU, and a lot of other tests, PET scan and all that. But these are the tests for this particular patient. That means where I suspect he's got cancer of the kidney. Okay, the diagnosis is between cancer and stone. So easy. Now you narrowed down already. Okay. Okay, now the investigations come back, the urine analysis, there is plenty of blood in the urine, okay, blood cells, RBC packed, okay, so there's no need packed field, that means every field you see all full of RBC, that means there is blood. Leukocytes negative, protein also negative, glucose is positive. Okay, now Japsim again, continue. What do you think of this investigation?
It shows that it's not an infection, so we can rule out the UTI.
Okay.
And it confirms our hematuria because there's blood.
Okay. And then the other one, which I forgot to write, the cytology was normal. There's no abnormal cells. So that means it's not really helpful. So only thing that you can diagnose from this is patient has got PEX with RBC in the urine, which confirms the patient's complaint. It is not something else, a dye or something like that. It is blood, confirmed hematuria. And the glucose, negative. Protein negative, glucose is positive. What's the implication of this, significance of this positive glucose? Tapsim?
Is it in relation to his diabetes?
Yes, okay, he's a diabetic, so you are not very surprised. So maybe it is not really significant in this patient as far as that his diagnosis is concerned. He's a patient, he's a diabetic, so his blood sugar may be high, and then you get glycosuria. Okay, so it is not really significant in this particular patient. Otherwise, it is significant. Okay, now this is the ultrasound of a kidney, one film. Okay, Roshan Rao.
Yes, doctor.
Okay, this is his right kidney. This is one ultrasound film. So what do you see on it? What can you interpret from this ultrasound?
There's a globular shaped mass.
Mm-hmm. So what do you think this lesion in the kidney? This is a kidney, okay? I already told you it's a kidney, so you don't need to worry where is this, where's the site of this scan, It's the kidney, left kidney. So there is a, how will you describe this mass here? This is the mass, okay? The all these four X here, between them, and there's a mass. So you can, how will you describe this mass?
I'm not sure, doctor.
You try lah, don't say don't not sure, you make an effort.
There's a globular shaped mass within the margins of the left kidney.
Okay, there is a, what is a globular shape? How you know it's globular?
It's circle and well demarcated.
Circular one. Globular means three-dimensional. Okay, this is a circular mass, hypoechogenic mass here. Okay, then you have to, if they give you the measure, you have to tell the measurement, 1 centimeter by 2 centimeters or whatever it is. Okay, which is within the liver, within the kidney. What other things on ultrasound you mention in a patient with ultrasound of a kidney mass? If it is a tumor, how you know it's a tumor or not? It's a malignant lesion or benign lesion?
The extension of the mass.
Okay, but Soma? See, always when you describe a mass, you must always describe the edges, periphery. Is it smooth, well encapsulated? Okay, in this case, here is very smooth, but here you can't see the margin. Maybe that means it has broken into the capsule. So that is a sign of malignancy. Okay, it may be not true, but that is one of the features. When you describe an ultrasound or a lump, you must always look size, shape, everything, the margin, irregular margin, and the surrounding tissue, whether there is a well encapsulated. When encapsulated, it is benign. Okay, Roshan?
Yes, doctor.
Okay, so same thing. What do you think of this? This is another film of the same patient.
There is a hyperechogenous mass within the margins of the kidney that has irregular margins.
Okay. Alright, good. At least better than the thing. So this all you must practice, So here you can say here is very well. The capsule is very clear, demarcated very well. But here you don't see it so well. Okay. So there is a lesion here measuring maybe 3 or 4 centimeters in diameter. Okay, which is hyperechogenic, and then the border is not so smooth and it's irregular in the lower portion of the lesion. Okay, which would to you it can be a stone, but it's more likely to be a malignant lesion. All right. Okay, now just now Japsim say next we'll do a CT scan. Alright. Kavita, what do you see on this? This is the right side. What do you see on this CT scan of the kidney?
There is like a loss of intervertebral disc between the vertebra.
Okay.
Um,
See here, here there's a kidney. Okay, left, this is the right kidney. Looks quite normal. Okay. This is the left kidney. Do you think anything normal, abnormal?
the left kidney lesion invade the psoas muscle.
Mm-hmm. What do you think? What do you think is this lesion? Is this anything wrong or not? Any lesion or not?
Yeah, there's a lesion, doctor.
Okay. So how will you describe this lesion? Where is it in the kidney? The kidney has got upper pole, lower pole, body of the kidney, or in the pelvis. So where is this?
It's in the lower pole.
Okay. So you think it looks like there's a lesion, hypoechoic lesion. CT scan is radiolucent. It's a radiolucent lesion occupying the lower pole of the left kidney. Anything else you can mention in this picture?
No, doctor.
So always I tell you, when you describe a lesion, you must, most important is the border. The border will tell you whether it is possibly a malignant or benign. So in this case, what do you think? The border, the boundary here. What is this? What is this tissue? This one is, what is this shadow?
Psoas muscle.
Okay, good. Psoas muscle. So the kidney lies on the psoas muscle. So you see the lower pole. Do you think it's a well encapsulated lesion?
Yeah, I think so.
But this part here, a bit irregular, suspicious. So we may have to, of course, look for other views and see whether it is anything. But over here, whether it is stuck to the, is it adherent to the psoas or not? The arrow shows here. Okay, so this area again suspicious. Is it adherent? If it is adherent, the tumor has penetrated into the capsule and come into the muscle. That means it becomes a stage 3 straight away. Okay, all right. Okay, this one again, Kavita, anything? What can you see from this CT scan?
There's a visible lesion on the kidney.
Okay, in this case, this is the kidney, this is the left kidney. The kidney is enlarged and there's a mass here. And this mass looks like very well encapsulated, except for this area here. Otherwise, it looks well encapsulated. So this is a mass in the, this is a different patient. This is the upper pole of the kidney, of the left kidney. All right. Any comments? Anything you're not sure?
Yeah, okay, got it.
Okay. So when you everybody, when you are given a picture, X-ray, ultrasound, or CT scan, important thing is describe what you see. Normally they will tell you, they won't put out, they don't expect you to know very much in detail. They just put up and show you, okay, like this. This is the picture of a CT scan of a patient with suspected kidney stone, kidney disease, tumor. So what are the findings in this you have to look for? Okay, any question? Okay, next one, let's see. Lesion limb. What are what symptoms and signs in this patient cause of worry? Which is a cause for worry for the doctor as well as for the patient. Lesion limb. Li Shen Lim, are you around?
Yes, doctor.
What do you think?
Maybe it's the gross hematuria with the associated with the loin pain.
Okay, loin pain and gross hematuria, and also so these are the two symptoms. And then one more, loss of
weight.
rate of pain. These are the three important things that worry you. Once these three symptoms which I put up just now, when you think of this, then you think more likely it can be a malignant lesion or not. Okay, what do the CT scan show? You have already mentioned that. What is the most likely diagnosis? Possible diagnosis? Lee?
Renal cell carcinoma on the left kidney.
Okay, good. All right, with hematuria. All right. Okay, what is the significance of left varicocele in this patient?
It's due to the compressive effect of the tumor on the left ureter, on the left renal vein.
Renal vein, not renal vein. On the left side, later I'll show you after the class, the lecture. There's the left testicular vein enters into the left renal vein at a right angle, acute angle there. So that if there's a tumor blocking the vein, it can cause varicocele. All right, secondary varicocele in the left side. So if a patient is an older patient, varicocele usually in younger patient. If an older patient, 50 something, this patient comes and then there's a varicocele, then you have to think of some secondary cause. Most of the time is primary. Varicocele is primary. You don't know what's the cause. That is in young patient. Older patient, you must be a cause, something blocking, a tumor blocking the testicular artery. So the kidney, the tumor is the most common. Okay, what are the treatment modes available? We'll come back to this later because after the lecture. Okay. Okay, now I go to the short lecture. Then we come back after that. I'll stop this, show you the video which I've recorded. Okay, can you all see? Okay. Okay, this slide shows the general outline of the urinary. Before you go on, this slide, the first 2-3 slides on anatomy. So the anatomy, you mainly look for the covering of the kidney, the various layers of the kidney. Capsule, fat, and fascia. Capsule of the kidney, perinephric fat, and the Gerot's fascia. Okay, so this is very important because when you stage the disease next time, and you will know, you have to see that. All right. System, which consists of a pair of kidneys in the upper abdomen, the ureters, which joins the kidney to the urinary bladder which is located lower down in the pelvis, followed by the urethra. Okay, the kidney is located in the upper abdomen. It is a retroperitoneal organ on either side of the vertebral column. Okay, where the main arteries of the abdomen traverse. It typically extends from T12 to L3. Okay, upper end is at level of the T12 vertebra, and lower end is around T3 vertebra. And the renal pelvis, which is in the middle of the kidney, is around L1 vertebra. The right kidney is slightly lower than the left because of the liver, which is located around here. The kidney itself is made up of three parts. The cortex, in which the tubules, millions of tubules are located. Then the medulla, where the collecting system is located. And the pelvis, which is the receiving or receptacle part of the kidney, which receives the urine before being transported into the renal pelvis and the ureter to be drained into the urinary bladder. The arterial supply of the kidney consists mainly from the renal artery, which arises from the aorta. And the venous drainage is through the renal vein into the inferior vena cava, on either right and left sides. The kidney itself is covered with a capsule of fascia known as the carotis fascia, the outermost layer here, which also covers the encloses the adjacent adrenal glands, which attaches to the upper pole of the kidney. The kidney is surrounded by this yellowish structure, which is known as the perinephric fat. Okay, this is the perinephric fat, which covers the kidney and act as a cushion to absorb the shock or some sort of all the trauma. And the kidney itself is covered with another layer of thickened area known as the capsule of the kidney. So the outer layer of wall of the kidney consists of a capsule, the perinephric fat, and the carotis fascia. This is very important when it comes to tumor of the staging of tumor of the kidneys. This is the outline of the venous drainage of the kidney. Okay, as I said, the veins drain into the renal vein on the right and left side, which then carries the blood into the vena cava. Of importance is the difference between the testicular vein on the left and right side. On the right side, it drains into the vena cava directly, whereas on the left side, it enters at a right angle to the left renal vein, which carries it in the blood into the vena cava. This is at a right angle, and as a result, there is some degree of stasis of blood in the left testicular vein, causing a slight dilatation, and explains the reason why varicocele is more often seen on the left side. Topic proper: renal cell carcinoma. Renal cell carcinoma, or RCC in short, is also known as renal adenocarcinoma. It arises in the epithelium of the proximal convoluted tubule of the kidneys and is frequently detected coincidentally during some routine physical examination. There are three major subtypes: clear cell carcinoma, papillary carcinoma, and chromophobe renal cell carcinoma. And the male to female ratio is 2:1. The peak incidence is between 65 and 75 years of age, and it is uncommon before the age of 40. If present in patients less than 46, there's a high possibility of underlying hereditary kidney cancer syndrome. Among the three major subtypes, clear cell carcinoma is the most common subtype, accounting for 83 to 88% of the renal cell tumors. What are the risk factors for this cancer? Age, as mentioned, it occurs in the elderly. More common in males, 2:1. Obesity is another factor. Hypertension, cigarette smoking, and medical conditions such as chronic kidney disease, patients on hemodialysis, patients post-transplantation, renal transplantation, and acquired cysts of the kidney. Family history of RCC is also another risk factor. Underlying von Hippel-Lindau disease, which is a condition where there are multiple cysts and tumors in various organs of the body. Excessive exposure to cadmium and asbestos are considered other risk factors. And very important is non-steroidal anti-inflammatory drugs. Abuse of these drugs can also lead to renal cell carcinoma. Clinical features of renal cell carcinoma. A significant proportion of patients with renal cell carcinoma are asymptomatic. Their tumors are only identified incidentally during imaging for other problems. Among the symptomatic patients, about 60% are present with hematuria, 40% with loin pain only, and 25% with a loin mass. The classical triad of pain, hematuria, and a loin mass is only found in about 15% of the patients. Unexplained weight loss and anemia, including fever, the so-called pyrexia of unknown origin, raised ESR, polycythemia, disorders of coagulation, and abnormalities of plasma proteins and liver function tests are some of the other symptoms. The so-called paraneoplastic syndrome is another presenting feature in a minority of patients. The finding of a left varicocele may be a presenting feature in another small percentage of patients. Paraneoplastic syndromes. Renal cell carcinoma is a classical example of a tumor that produces ectopic hormone production. Okay, these include erythropoietin, which produces polycythemia, renin, causing hypertension, insulin, hypoglycemia, adrenocorticotropic hormones or ACTH, which produces Cushing's syndrome, parathyroid hormone producing hypercalcemia, and gonadotrophins, which produce gynecomastia, amenorrhea, reduced libido, and baldness. Other conditions of paraneoplastic syndrome are hematological, which produces anemia, and metabolic defects, which cause pyrexia of unknown origin. Investigations that you can do for patients with renal cell carcinoma. Okay, first you have the full blood count. You look for low HP and anemia, and urine examination especially for cytology, where you look for positive malignant cells. Others include abdominal and kidney ultrasound, looking for hydronephrosis, mass lesions in the kidneys, and also the presence of stones. CT scan can be done usually to detect mass lesions in the kidney and other adjacent organs, and also for lymph node and staging purposes. Bone scan, PET scan, and chest x-rays are all done for the staging of the renal cell carcinoma. Okay, this is an ultrasound picture of the kidney. Left kidney here. This is the kidney. It shows an irregular mass located, a solid mass located within the capsule of the kidney. Generally, the capsule seems to be intact, except in some areas here where it looks like probably could have breached the capsule. We need further detailed examination to detect the involvement of the capsule.
Next, we come to the diagnosis and staging of renal cell carcinoma. The classical triad of hematuria, loin pain, and loin mass are found only in 25% of the patients. The vast majority of them are diagnosed on incidental findings, especially incidental ultrasound for other abdominal conditions. Ultrasound, the initial investigation of choice, allows differentiation between solid tumor and simple renal cyst. Whereas staging CT scan imaging with contrast enhancement of the chest, abdomen, and pelvis are very good in detecting metastasis in these areas. CT scan guided biopsy for tumors less than 3 centimeters in diameter and with no evidence of metastatic spread, and when the nature of the lesion is uncertain, then ultrasound or CT scan guided biopsy may be effectively used to avoid unnecessary nephrectomy for a benign disease.
This is a CT scan of a patient with a tumor here in the left kidney at the lower pole of the left kidney. Okay, here it seems to be well encapsulated except at the point of the arrow here where it seems to be stuck and adherent to the psoas muscle. This is a tumor in the upper pole of the left kidney here. Here. Also here it seems to be well encapsulated except maybe for this part here. Okay, so otherwise it seems to be well encapsulated. This is another CT scan of another patient showing you a well encapsulated tumor in the lower pole of the right kidney with generalized bilateral hydronephrosis. And here the same tumor here in the lower pole of the right kidney, large tumor, probably is infiltrated into the hilum of the kidney here.
This is a simplified staging system for renal cell carcinoma using the T&M classification. Okay, T1 is a tumor that is limited to the kidney and its size is less than 7 centimeters. T2, tumor limited to the kidney, but now the size is greater than 7 centimeters. T3 is ingrowth of the tumor into the perinephric tissue, but not beyond the Gerota's fascia, or if the tumor thrombus is present in the renal vein. T4 involves ipsilateral adrenal gland involvement or invades locally beyond the Gerota's fascia. Okay, this diagram summarizes the stages of renal cell carcinoma. Okay, stage 1 is here, a small lesion less than 7 centimeters within the kidney parenchyma. Stage 2, same, it is present within the renal parenchyma, but the tumor now size is more than 7 centimeters. Stage 3, the tumor, irrespective of the size, this involves the perinephric capsule of the perinephric fat or the perinephric tissues involved. That's stage 3. Stage 4, here, it is irrespective of the size of the tumor has penetrated and breached the capsule and the Gerota's fascia, the outermost fascia here. Or it has also, if it is in the upper pole, it involves the adrenal gland. And in stage 3, the renal vein is also involved with tumor invasion.
A bit detail into the treatments available. First, as I said, surgery, which consists of partial nephrectomy, where part of the kidney is removed. The newer form of this treatment is known as the nephron sparing surgery, which is a lesser surgery than partial nephrectomy. Then we have total nephrectomy, where the entire kidney is removed, and radical nephrectomy, where the kidney and the surrounding tissues are removed. Depending on how far this disease has spread, more extensive surgery may be needed to remove the surrounding tissue, including the Gerota's fascia, the pelvic lymph nodes, and the adrenal gland. Radiation is another form of treatment, which is usually done together with surgery, and this can be either external or internal radiation. Then the other common treatment is chemotherapy, use of IV anti-mitotic drugs. The other modes of treatment include biological therapy, also known as immunotherapy, which works with the immune system of the body to attack the cancer cells. Then the targeted therapy, where the drugs are used to attack certain cancer cells without damaging the healthy cells. Then the use of vaccines and cytokines and sometimes hormonal therapy. These are all different modalities of treatment, new modalities of treatment that are reserved for more advanced cancers.
Okay, this is a picture to show you radical nephrectomy. The whole kidney is removed with the tumor. The renal artery and vein are ligated. The ureter is also removed. Okay, whole kidney with the perinephric fat is removed. Renal fascia also removed. Ureter is removed. Adrenal gland, depending on the location of the tumor. If it is in the upper pole, adrenal gland is also removed. And of course, if there are adenopathy or lymph nodes are involved at the ila region, the lymph nodes are also removed. This is radical nephrectomy. Okay, another picture showing a tumor here in one of the poles of the kidney. Okay, radical nephrectomy is done to remove the kidney, perirenal fascia envelope, that is the perinephric fat, and the Gerota's fascia, renal gland, and the regional lymph nodes, including the ipsilateral para-aortic lymph node. However, patients with tumor less than 5 centimeters located at the inferior pole of the kidney, the adrenal gland can be spared. Okay, if it's the inferior pole, if the tumor is less than 5 centimeters, then adrenal gland at the opposite pole is removed. It's spared. Okay, this diagram shows partial nephrectomy and a new way to eliminate kidney tumor and preserve the part of the kidney that is not affected by the tumor. Okay, the tumor is locally excised and then it is sutured and the wound is closed. Okay, here partial nephrectomy and radical nephrectomy differences. Here locally excised and the wound is closed with suture. Over here, the whole kidney with the Gerota's covering fascia is removed with the ureter, and then the renal artery and vein are ligated. Okay, what is partial nephrectomy? It's the complete removal of the primary tumor while preserving the largest possible amount of healthy renal parenchyma. This is indicated in patients with T1 tumor and normal contralateral kidney. It is strongly recommended in the following patients. First, patients with RCC who have only one kidney, anatomically or functionally. So whatever kidney you have, you need to preserve. So in these patients, partial nephrectomy is strongly recommended. The second group of patients are those with bilateral synchronous renal cell carcinoma. So you cannot remove both kidneys. So you try to preserve as much as possible by doing a partial nephrectomy on either side. And third are those with von Hippel-Lindau syndrome, which is a precursor of RCC. In these patients, whatever lesions are seen are removed by local excision, as in partial nephrectomy. Partial versus radical nephrectomy. Whenever possible, partial nephrectomy should be the preferred treatment. Compared, long-term cancer control are comparable. The cancer control by partial nephrectomy is comparable to radical nephrectomy. Lesser risks are involved if in chronic renal insufficiency and proteinuria. Lastly, we come to some very conservative treatment with the radiofrequency ablation and cytotherapy for localized tumors. Alternate strategy, these are strategies for elderly patients who are at high risk of radical nephrectomy and who are unsuitable for surgery. It is considered for patients with growth more than 3 to 4 centimeters. Completely destroy all the viable tumor tissues by the system of treatment. It's done either laparoscopically or percutaneously under CT or ultrasound guidance. The problem of this procedure, localized procedure, is the high recurrence locally after ablation of these tumors. Okay, next we come to prognosis. Prognosis, again, fundamentally depends on the stage of the disease. In stage 1, the 5-year survival rate is 95%. That is when the tumor is less than 7 centimeters and confined within the kidney is less than 95% survival rate. In stage 2, when the tumor is more than 7 centimeters but within the kidney, the 5-year survival rate is 88%. Stage 3, when the tumor in major veins or adrenal gland within the Gerota's fascia or regional lymph nodes are involved, the 5-year survival rate is 59%. And in stage 4, the tumor extends beyond the Gerota's fascia and the regional lymph nodes are involved, the 5-year survival rate is only around 20%. So in stage 4, it's around 20%. Stage 1 is 95%.
Some important points to take home from this lecture. Renal cell carcinoma is not a very uncommon condition we see in our patients. The classical triad of loin pain, loin mass and hematuria only occur in a quarter of the patients. The vast majority of patients tend to be asymptomatic with vague symptoms. A vague aching discomfort over the loins with loss of weight should arouse the suspicion of renal cell carcinoma. Hematuria remains the most important initial symptom that brings the patient to the doctor. The hematuria in renal cell carcinoma tends to be painless and total. Varicocele occurring in older patients should also arouse the suspicion of a renal cell carcinoma in the left kidney. Paraneoplastic syndromes tend to occur in a small number of patients, and this is due to ectopic hormone production. We should also important manifestations which land the patient in the wrong doctors for diagnosis. Okay, can you on your video for a while? Since you have got since we started late, got another 5 to 10 minutes more. Okay, any questions or not? Sue?
No, doctor.
No question, Okay, so this is a summary of renal cell carcinoma. Okay, as far as you are concerned, it is a very important question for clinical case. If a patient with a mass in the loin and with or without hematuria, this is an important clinical case. Okay, so this is how I would suggest that you go about plucking the patient and presenting. All right. So the prognosis is, I think, don't worry too much of the details of the type of surgery. Basically, is partial nephrectomy, radical nephrectomy. Nowadays they have what do you call this, nephron sparing surgery, and then the local effects, the radio ablation for patients who are not fit for surgery. So these are the few things that you must know. And I think the most commonly done is radical nephrectomy. Okay, whereas partial nephrectomy can be done, but you need centers where you need some equipment and extra monitoring. So only in the big centers they do this nephron sparing surgery and all that. Okay, it is not widely used. So the most commonly done for early localized cancer is this used to be radical nephrectomy, but of course now is partial nephrectomy. Okay, so the survival rate for local disease after radical nephrectomy, 95%, 5-year survival rate. Stage 4, 20%. Okay, so if you have no question, then I just come back to show you a few MCQs, 5 MCQs before we go back. All right. Come back to just now the PowerPoint. Okay, before we go to the MCQs, here the treatment mode available now, I think you should be able to understand the 3 types of nephrectomy, and then radiotherapy, chemotherapy, and all the others. All right. So the most important is surgery for kidney cancer with post-operative radiotherapy. If it is more extensive, it is rated secondaries, then you may want to give chemotherapy. So these are the mainstay of treatment. Okay. Okay, now we come to, okay, we start with Sue. Wait, let's see. I see the answer is there already. Okay, wait, let's see. I have to go back to this. Okay, so can you start? First question, first 2 questions.
Renal cell carcinoma has been more commonly associated with which of the following disorders? B. Von Hippel-Lindau disease.
Okay, I think quite straightforward. So the renal carcinoma has got a long list of risk factors. So you must be able to MCQ. They like to ask you on this. Okay, so you have to memorize all those. But the important ones will be smoking, some chemicals, and this congenital type of conditions. All right, familiar. The answer is B. All right. Okay, next one. You carry on, Sue.
Which of the following is associated with the highest risk of renal cell carcinoma? Obesity.
Anybody? Anything else? In fact, all of them also risk factors. But I think the highest, I told you, among these factors is, the answer given is B, smoking. Okay, smoking is the In fact, all of them also risk factors. Just now I put a long list of conditions there, and among them, I think smoking is the highest. Okay, so it's very important for you to get the detailed history of his smoking, chronic smoker for how long and all that. So getting a social history is very important. Okay, next one. Question.
Which paraneoplastic syndrome is not typically associated with renal cell carcinoma?
Is not typically associated.
C, doctor.
C. Anybody disagree? In fact, all of them also can be associated, but it's not typical. That means it's not very commonly occurred. Erythrocytosis, I told you that erythropoietin, it can secrete paraneoplastic erythropoietin, increases the HB. Hypercalcemia because of parathyroid hormone. Okay, this syndrome of SIDH is, I think, Russian is right. Okay, C is the least of them. Among these factors, this is the least not typically associated. Okay, right. Okay, Roshan, the next one.
Which of the following is typically the imaging study of choice to assess patients for renal cell carcinoma? CT scan.
Okay, all this we discussed just now. What do you think is what do you think? You think the CT scan is the most important? Anybody else thinks otherwise? Okay, I think you're right. So the answer is D. Renal CT scanning, not renal angiography. So most important is CT scan. Nowadays, as I told you, the 3 examination that you want to do is a KUB X-ray, KUB ultrasound, and CT scan. CT scan can also be used for biopsy. CT scan guided renal biopsy, percutaneous biopsy. Alright, so that is very important. So these are the 3 preliminary, and CT scan, apart from for diagnosis, it can also use for staging. In staging, you give contrast, CECT, contrast enhanced CT scan. So you give contrast, then you can find out the stage of the disease. So staging also important. CT scan for diagnosis, for biopsy, as well as for staging. So now I think CT scan, the ultrasound is just a survey. It's a preliminary examination. But CT scan is the most important now. Okay. Then IVU or urography, expiratory urography, sometimes done before CT scan came in. We used to do a lot of IVU. Okay. But nowadays, very rarely we do. So IVU has become very much bottom line now already. Alright. IVU means intravenous urography. So the most important now is CT scan. Okay, the last question. Question, can finish it?
Which of the following is most commonly performed treatment for localized renal cell carcinoma? Radical nephrectomy. A.
You think it's A? Okay. This is, I think, if you read the books, they will say partial nephrectomy is the #1 choice now. Okay. But in practice, I think radical is still the most widely used, because radical, not enough, we don't have enough expertise to do radical nephrectomy. So overall, still I think radical. But I think the answer given is B, which I think is the right thing. Nowadays, when I used to do this urological surgery those days, we do radical nephrectomy. No question asked. There's no question of partial nephrectomy. Because partial nephrectomy, there are some technical problems. Because you remove part of this thing, so you want to know the demarcation. And then you got to cool the kidney to prevent it from becoming ischemia. You must understand, the kidney is the most sensitive organ to ischemia. So once So you have to clamp the arteries individually. So all this needs more technically more demanding. So, but now I think the standard treatment is partial nephrectomy. In your presentation, if you say radical, I think they will accept it also. Okay, and then you must know what's the difference between radical and partial. Okay, then the indications of partial, which I mentioned just now. If the patient has only one kidney, then there's no question of radical nephrectomy. Straight away you say it's for partial nephrectomy. Or if the patient has got chronic renal failure, so you couldn't remove one kidney, that means the chances of renal failure is much higher, complete shutdown. So you want to do a partial, try to preserve as much as possible. Okay, and okay, so answer is B. Okay, so but you have to know the difference between. So when they come to a clinical, of course MCQ you can put, but in a clinical case you can be able to give reasons for and against. Okay, I think that's all. Any question before we stop? Okay, today only 30 over people came. Okay, I need somebody to be like coordinator, like in year 4 I have somebody who regularly comes. I get a coordinator who doesn't come, only comes once in a few months, no point. So that I can pass the message to you all. So anybody, I think one of, maybe I suggest is Sue Sue, Teo, I think you come very often. Most of the time you are there. Maybe you can be like a coordinator, can or not? So I send the message to you, you just forward to the others.
Okay, doctor.
Okay, because now we already got the WhatsApp group, so you can put that for everybody. So send them the reminder, and then also this thing. Okay, because I put it there, I don't know, some people don't see also, I think. Alright, so those doing surgery, try to come. The others, maybe you're busy, then it doesn't matter, but try to come as far as possible. Because we have to try to get more people to come, otherwise not really worth, because otherwise I will also call it. Maybe I should also invite some of the year 4 to come, those doing surgery. Okay, because my year 4 attendance seems to be much higher. Okay, so is you okay?
Yes, doctor. Okay.
And nothing much. You just have to, since you're always here, so I can pass the message to you. Okay, any problems and all that. Okay. Okay, and then if you have any suggestions, they can give it to you, so you can pass it to me. Okay, that's all I think for today.
Thank you, doctor.
So I will send you the PowerPoint. The questions are all there. You can just go and answer the question. I think quite straightforward. Okay, then I'll see you all in 2 weeks' time. 2 weeks' time will be, when will that be? It's July, isn't it? Somewhere July. July 8th, I think. Okay, today is the 24th. Yeah, okay. All right. Okay, see you all. Thank you all for coming.
Thank you, doctor.
Thank you, doctor.
Thank you.
Thank you, doctor.
So try to get more people to come. Otherwise, we can't have more sessions. I'm quite tough also to have a lot of sessions. I know it's MCO and all quite difficult. I think everybody is so depressed and very anxious. But what to do? We have to carry on. All right. Okay, Roshan also come quite often. So maybe anything. So the regular ones I can contact you all. Okay. Then when I put up something, at least some of you reply, okay, receive, okay, or something. Otherwise, I see, I put the message for tomorrow. I see until now nobody has replied. So I don't know anybody coming or not. So at least acknowledge that you have seen, okay, or something like that. So at least I know that quite a number of you have seen. Alright? Okay, thank you.
Thank you, doctor.
Thank you, doctor.
So I'll put up the list of topics which I'm going to cover. yours is mainly going to be clinical case lah. So if possible, I would want those doing surgery to discuss the case before I give you the short lecture. So that's what you can liaise with your group that is doing now. Okay, because it's for you all, no point I going through everything, and then I'm not going for the exam, so you all are going. So I want you all to be more clinically oriented, discussing the case as though you're given a long case. Okay, thank you for coming.
Thank you, Doctor.
Okay, bye.